Being unsure on whether or not a fallen person is safe to lift often lead care staff to default to calling an ambulance, when in fact the fallen person may well be safe to lift or move.
HelpFall is a digital post-falls decision-making tool that supports you to safely assess a person who has fallen and helps you decide whether to assist them from the floor using safe manual handling techniques and equipment.
So, hello everybody, and welcome to the webinar. So today, as you're all aware, we're going to be covering off how HelpFall is transforming falls management in care homes. And specifically today, we're going to be focusing on a project that North East Essex have been running and going into that in a bit more detail. So we're joined by Mark and Donna, who will introduce themselves in due course. In terms of how the session is going to run, Mark's going to be going over in a minute a little bit around the overall problem, and then I'm going to be going over a bit around the actual solution, if you like, or how we've assisted North East Essex and what the offering actually is. And then Mark's going to be going into a bit more detail in terms of how the implementation has worked, kind of from the initial concept to now as a fully functioning project in reality. And then Donna and Mark will go over what the results have been. And we have got a video of some of the care homes talking about their involvement in the project and the impact that it's had. And then we'll jump straight into the Q&A session. So without further ado, Mark, over to you. And you can introduce yourself, tell everyone who you are, what you do.
Thank you, Grant. So my name's Mark Shorter. I'm Head of Transformation in the North East Essex Alliance, which is part of the Suffolk and North East Essex Integrated Care Board. And I've been part of the team that have been commissioning this particular piece of work. Okay, so I don't really need to convey too much about this really, but I think we all fully understand that there's been a huge amount of pressure, not only on the ambulance service, but our emergency departments through the NHS right across the country, particularly with the category 3 and 4 ambulance call outs, which is where the falls responses often fall into. They have had some significant pressure, very increased response times, and unfortunately that has resulted in a lot of long lies for patients, which then unfortunately means that they deteriorate with their condition as well. What we were finding with our care homes in particular was that a lot of the safeguarding policies and procedures that they adhere to around people that have fallen within their care, it meant that the staff were very hesitant to lift those fallen residents from the floor. And a lot of the policies were saying call 111 or call 999 immediately, when that was not necessary for a good proportion of these patients. So we really wanted to do something a little bit different that just boosted that confidence for staff within our care homes, and also then reduced all the pressures on our ambulance services having to respond to all the different falls within our care homes and across our system.
Oh, there we are. So thanks, Mark. That's a good overview. And I guess the problem is only exacerbated, if you like, with the aging population and the fact that we have got an older generation that are increasingly complex in their care needs, and more being required to be managed in the community, if you like. Now, this part is around what actually is HelpFall and what is the offering. So, as many of you would be aware, there's a large number on this call. Majority of you would probably be somewhat familiar with who we are and what we stand for. But effectively, over the last few years, we've been doing quite a bit of work with a number of different ICBs in terms of their falls offering and supporting them through that process. Now, it's what we've become acutely aware of over the last few years and has led to the development of HelpFall is that whilst you can equip care staff with the ability to lift somebody, I'm talking about a piece of equipment, be that a hoist or a razor chair, actually the bigger barrier that we've got here is that, as Mark pointed out, some of those policies and some of that inbuilt maybe risk aversion from the care staff is causing a challenge, and maybe sometimes not actually acting in the best interest of that fallen individual. So that was the kind of background to HelpFall, and we then decided to partner with South Western Ambulance Service in the creation of HelpFall. Now, we believe it is the new standard in post-falls decision making, but in essence, it's a digital tool that is designed to help non-clinicians assess whether somebody is safe to lift. Now, it works very simply, as you can see on the screen there, on a traffic light system. So you've got red for major injury, amber for minor injury, and then green for no injury. And effectively, the care staff scans the QR code, takes them through to the HelpFall page. They then answer a number of really, I think it's 10 really simple questions regarding that client. And then based on their inputs, it advises them on what the next best step is. Now, it is generic in its own right, in the sense that it's for every situation. And it's not obviously to override somebody's gut feel or any clinical decision making, but it's there to kind of prompt them and make them feel like, you know, they're supported throughout that process. So once they've gone through the different questions, it will get to a point where it tells them what to do, and then they can fill in a report. So that report will capture everything that they've filled in, but then also there's some free text fields, which kind of encourage some of that. I know one of the questions that they're suggested to answer is, what are the potential causes of this fall? And it kind of encourages that full picture, if you like, to kind of actually analyse why the person's on the floor in the first place. But it will then, that report, which you can see on the bottom in the middle there, is then emailed through to any email address that they fill in, and that can then be uploaded to the patient records and forwarded on to any additional service like a GP. And what was really interesting, we'll probably touch on this in a bit, was when we piloted this with North East Essex, one of the outcomes that was almost, well, it was unexpected, was the fact that it sends through a report as like a snapshot in time was one of the biggest things that enabled the confidence of the caregivers, because as you'll see in a bit, it's kind of almost taking some of that risk off their shoulders, or responsibility for it. And then just a final point I wanted to say, and Mark may cover this, I'm not sure, but we can then collate that sort of data into some more management type information and kind of come back quarterly and say, this is how many falls you've had, this is how many within each category, and suggest some of those insights, such as, I don't know, the majority of the falls have happened between this time frame, or majority in this location, which kind of then encourages some of that falls prevention thinking as well. But Mark, over to you. So we're on talking about how you've made it happen.
So actually, it was Lee Toner, who was the commissioner prior to me coming in to this particular piece of work, who had been busy identifying our top 20 care homes that had the most amount of falls within North East Essex. Just to convey, we have North East Essex consists of Colchester and the Tendring area, which includes Clacton. So we do have a coastal community, and we have a really high proportion of care homes considering the size of our population. Also Tendring, 1 in 3 people nearly are over the age of 65. So we've got a really strong and heavy ageing population within that particular area, and a lot of the care homes are based within the Tendring area because it is by the seaside. So we did some work with Donna and our nursing quality teams, who are in constant contact with our care homes, to identify those top 20. We then obviously picked up that we had some ageing well funding that we could probably utilise to support some of this work, and we delivered a pilot with the care homes to put some Falls razor chair equipment into those particular care homes. And that was when Grant and the Felgains team proposed to us this opportunity to test the HelpFall app. I would say the really one key message in terms of engaging with the care homes was that Donna and the nursing quality team had a very good relationship with all of the care homes. They understood what the pressures and systems were for them and were able to initiate those initial conversations. So it wasn't just a Felgains provider or someone just calling the care home kind of ad hoc. There was a lot of work that went into engaging with the care homes to discuss whether it was something that they would be willing to undertake, whether they had lifting equipment already or not, and how it could be utilised. So we really had that buy-in from all of the 20 care homes that took place as part of this pilot. The MOUs were a very simple bit of paperwork that was signed by the care home and returned to the ICB for record keeping. But it just simply outlines that this is a pilot, that we, as the ICB, were paying for the lifting equipment chair, and that they were undertaking a pilot to also trial the HelpFall app. So it's just a really simple agreement, basically, that the care homes could then understand and sign and return. Grant and the team went out to all of the care homes in person, delivered all the training on the actual lifting equipment to make sure that the care homes were really engaged with that process and knew what they were doing and how to use the chair, because we all know that there's some things that probably go and sit in some of our care homes and collect dust over time. So we just made sure that they really understood how to use the equipment, but also just maximise the uptake and engagement with the HelpFall app, and also make sure all the MOUs were signed. And that in-person service was again really key to the engagement process within this whole pilot. We've then had really regular contact with the care homes, not only through the Felgains team, but Donna and the nursing quality teams, to really understand how they're getting on with it, troubleshoot any problems, and just pick up things and nip them in the bud really quickly and early to make sure that they were happy using the equipment and the HelpFall app. But that's enabled us to then monitor the HelpFall app with all of our reporting and data to get some really key outcomes of what difference it's actually making within our system. Okay, so some of the impacts that we've seen. There has been a clear reduction in ambulance call outs to the care homes taking part in this pilot. Donna's going to hit on this in a moment. So, but there is a real sense of confidence within those care home staff that they're doing the right thing, and they feel reassured by the app that they are making the right decision. One big difference that we've seen is that the amount of people going into hospital has significantly reduced. I think the targets were around 80 to 84% of the people within the care homes that have been accessing this app have actually been then dealt with within the care home. However, the amount of people that have been going into the emergency department through an ambulance conveyance, and then often we know were returned with no further action, they've just literally gone in and had a checkup. So the no abnormality conveyances have reduced within those care homes from 27% to 0. So we know the people that are going into hospital need to go into hospital, and the ones that can be dealt with and managed within the care home and the community itself are having that right place, right time and right care kind of process. And obviously we've had less footfall then going through the care homes because they've been able to manage the care themselves. So you're not having lots of other services coming in or people coming in which can disrupt the care home, particularly because we know these happen at night in a lot of cases. But it's also significantly reduced the amount of long lies and the issues that can bring for the patient deterioration as time goes on when they're on the floor. So we've had a really swift, quick response to this, which has enabled the system to come under less pressure, which is exactly what we were looking for at the start. So I'm just going to hand over to Donna. So Donna, if you want to introduce yourself and talk a bit about what's going on with the care homes, I'll be grateful for that.
So I'm Donna Chandler. I'm a care homes nurse working across all of the 167 care homes in North East Essex as part of SNEE. So obviously this pilot went out to 20 care homes that were identified with all of the previous conversations and the MOU as previously discussed. So I won't go back over that, but more on a personal level, interacting with the care homes. There has been really, really positive feedback about the equipment and the app. So the equipment itself, it's kinder, it's less scary. You're not swinging in the air. You're raised on this chair, as it says, a raise a chair and into a sitting position. So I don't know, for those who've been in a hoist, it is a horrible sensation. This is much nicer. It's more comfortable. So it's much better for our patients who suffer with dementia. It's more of a natural process to go into a seated position. Care staff have felt empowered using the HelpFall app because it's given them that assurance that they can do a standing risk assessment there and then, that's documented. That is their clinical rationale. They can use that to make that decision for the patient, the right decision for the patient, rather than being worried or scared that they might be injuring the person further. They've got that risk assessment. The data that comes back, they can use to root cause analyze the situation, find any trends. So it has empowered them, and the care homes themselves have felt that they are more of an independent, more informed, higher skilled base of staff. So it's been an all-round winner. There's not many negative aspects of this system that I can see at the moment, and it was put in place or formulated by the ambulance staff. So it's, the red, amber and green is a very simple system, and it keeps the patient safe. So it's easy to use as well. You don't need to be medically minded. You don't need to be a qualified nurse. So all care staff are more than capable of using HelpFall. The razor chair itself is less space consuming as well than a hoist, I would say, because of the legs of the hoist. So I'd say you could get into a smaller, because patients never fall into the middle of a room, so you can get into a smaller position. It's very easy to move around, so you can go in a little backpack onto the carers' backs with the app, and they can scan the app while they're there. There's a little scan, so you can scan the QR code. So you can scan the QR code using the HelpFall app, brings it all up, email it to the patient's records, so you have your instant record already done for you. So it's a really simple process. So I would advocate it. I'm not sure there's much more to say about it, but it is empowering, and with the aging population and the amount of care homes we have and the pressures on the system for care homes to be more able to self-care, it's all about self-care, the best care, and as Mark said, it's the right care at the right time by the right person. So you haven't got an ambulance crew marching in to scare your patient, which can feel intimidating and scary. Thanks, Donna. That's excellent. I think between you probably covered the majority of it. I think for me, my personal highlight from the project has probably been seeing that data from the no abnormality conveyances. We are dropping that down from 27% to 0%. We're saying that the people that are going to hospital needed to go, and the people that didn't are staying in the care home. And that is just amazing on so many fronts. Yes, we're reducing the number of ambulance call-outs, but actually it's those with reducing those conveyances to hospital. Just a quick point, if anyone does have any questions, keep popping them in the Q&A. We'll be getting to that shortly.
Mark, I don't know if you had anything else to say in terms of the quarterly reporting and sort of tying in with Jared on the data side of things to kind of give you a bit of an insight. Is there anything to say on that? Or
Yeah, I mean, obviously data's great fun, Grant, we all know that. Our team here at the ICB within our business intelligence team have been not only looking at the care homes that have been using the app, we've been looking at the care homes not using the app. And there has been a significant increase then in some of the care homes not using the equipment and app, sending people into hospital, when we can see a significant reduction with the people using the equipment and app. So we know this is making a difference in our system. Excuse me, and the data has just been really key to be able to see that. But it also enables us to just have that regular conversation, not only with yourselves, but pick up any issues as we go through, identify some trends as we've just picked up on, and it's helping us to understand where we need to go next in terms of our delivery moving forward within the ICB.
Yeah, that's really good. That gives a good overview.
Just to say that the enhanced health in care homes, the framework for care homes, has a clear section on IT and the usage of equipment, so it clicks into all of those boxes as well. So we know the enhanced health and care homes framework is it's the push at the moment from the top down from NHS England. So it does tick all of those boxes as well that we utilise in IT and digital, and it works really well.
We were hoping that one of the care homes might be able to join us for this next bit to kind of give some real life feedback, but they weren't able to, unfortunately. So we have just pulled together a brief video with a couple of the care homes just talking about some of the feedback that they've had. It's 90 seconds long. After that, we'll jump into the Q&A.
So before we had the Razor 2 and HelpFall would just purely be a judgment call, but then it would result more than likely in a 999 call.
It would be phoning the paramedics and going through the checklist with them, or the senior carer on shift, using their training, but it would mostly probably be guesswork.
So since we've had the Razor chair, we have had a few times where we've had to use it. I did use HelpFall to obviously ensure that I was doing the right thing before manoeuvring the lady. By going through all the checks, I noticed that it was okay for me to stand her. So we used the Razor 2 to stand, and then obviously we transferred from the Razor to her chair. But yeah, and then I filled out the report and sent that over to our email.
Less hospital admissions, definitely, because using the protocol that you go through and answering the questions, they can tell you whether it's sort of a minor or a major fall. It's more dignified for them to be raised up if they're able to do it. And they seem to be a lot better off after the fall. They're not as traumatised because they've been lifted up nicely and dignified.
It is helpful. It is really good, and it takes a lot of stress off of us. Obviously the HelpFall gives us that little bit more reassurance when it comes to our decision of moving.
I think every care home should have one, to be honest. It's more dignified. It's just so much more helpful. Somebody has a fall, you don't worry and then have to waste time by phoning the paramedics of what do I do. You've got it right there, and then you can help this person up. And it's just a quicker process and it's safer.
Let's hop onto the Q&A section. I'm going to be joined by my colleague Natalie, who's been involved in some of the development work of the project. So we'll just bring up the questions. Natalie, you can hop on screen. Right. So I can start with the top one. On there, Joanna, be nice to see how the actual app and how it works. Absolutely fine, we can do that. There is another webinar where we have gone through that. There probably isn't time to do it today. We can either hook up after this session and do something directly, or I can send the link through for the other webinar too. Next one down. Can I clarify the training available to use the app assessment and equipment? I think the comparison document for commissioners indicated all training was, just need to press see more, online. Has this been accepted in all homes, particularly those that may have had a history of being more resistant to lifting? Is the behaviour change supported by yourselves somehow, or does this all need to be locally led? Wow, quite a question there. Let's dissect it and pick up some of the bits separately. So I think the comparison that commissioners indicated all training was online. I don't know specifically which document that was on. Mark, maybe you can comment on that.
No, I mean, obviously we've done the training with the care homes directly, face to face, in person, with regards to the equipment and the HelpFall app. I'm not quite sure what document that's referring to in terms of the training being online. Donna, do you know anything about that one?
I don't, but I think it may be the question may be around people. How did people buy into it? Have we had to do much pushing and to get them to buy in? But I think the answer to that is it was the prequel to rolling out the pilot, wasn't it? It was the conversations that were had initially, the memorandum of understanding that everyone. We needed to see that they were carrying the pilot through, that it was a pilot. That's why the pilot was funded, and that they had to do that reporting. There hasn't been, so the reporting then goes, obviously it reports back to Felgaines, which is where we get the quarterly figures from. We have had to ring some of the pilot homes because they were using the Razor Chair, but not using the app to report. So we did do a little bit of that locally. A couple of care homes were revisited to go back through the training where there'd been a change of staff or anything like that, which Felgaines were very good, and we linked the care homes back into Felgaines. Felgaines went back out. So I think the fact that the training, the specific training around the use of the chair was face to face, and I think that was a big winner.
Yeah, I would agree. And look, let's be honest, we are dealing with quite a tricky thing with a behaviour change, as you rightly point out. So there is always going to be some of that hesitancy. And I guess it's about dealing with it on a case-by-case basis and us being prepared to assist with some of those more challenging cases and going back out. Next question then, I trust we answered the correct last one. How do you deal with blood thinners and NICE guidelines for head injury following a fall? Not a major head injury. Barry, trust you to answer that question. No, I'm kidding. Natalie, it might be a good question for you to pick up.
Yeah, good. So the short answer is that the algorithms flow has been designed to take into account the NICE guidelines around blood thinners. And if there is no signs of major head injury, but somebody is taking blood thinners, then we will refer onto a community provider for some follow-up. But we have completely followed the NICE guidelines throughout the process. Okay, well, let's move on that.
How does it differ from iStumble, please? Well, probably a few of us that could answer that. I'll maybe go first. So some of the key differences, if you like. Look, let's be honest, iStumble is a great tool. It's been out for ages. It's integrated in many systems. Some of the challenges that we saw with it is that it is very simply black and white. It's call 999 or not. And what we've tried to do with the creation of HelpFall is tie into some of those community providers, such as your GP and that sort of thing. The other difference, and coming back to something that we got out of the pilot, was the reporting element. So with HelpFall, once you've gone through the questions, it gives the ability to fill out a report. Now, that's something that's massively boosted the confidence of the caregivers, and is something that I'm not aware is a functionality on the iStumble algorithm.
Just to pick up as well, Grant, iStumble was designed some time ago, and that was before and prior to things like our urgent community response services and things being in place. So you're right, it very much does point to a pickup or 999 call out, where there are a number of other options now, as you mentioned. I know you picked up on GP, but urgent community responses are now in every single locality. They are there to support the holistic assessment of those patients within the 2-hour response time. And we have been working with the care homes to ensure that they're fully aware of the UCR, that they're there to be referred into, and trying to link the HelpFall app and Falls chairs in with the UCR team, so that if there are kind of minor injury or kind of some medical concern, that we can either have a community nurse or a therapist out to do a holistic assessment to that patient within 2 hours. And it's probably a much more appropriate response than letting them lie on the floor for, let's face it, and sometimes in the recent past it's been 8 to 10 hours plus for an ambulance to come out, and then going through the whole emergency department system. So just to pick up on that, where I stumble will probably differ from that HelpFall app. We have that amber section that says you need to call someone, but it's not necessarily 999.
Okay.
And just building on that, Mark, is probably another key difference is that with HelpFall, for every question, there is a specific set of suggested actions. So it's more than just a checklist of symptoms. It will actually advise what you should do in each of those scenarios.
That's good. All right, so there's one question there from Dawson. Is the form digital? Yes, it is. In short, there is a paper-based version which we would issue to care homes as well, but it is a digital form. Now, one for you, Mark, probably. Do you have a copy of your MOU, and what does it cover?
So yes, we do have copies of the MOU, and I'm quite happy to share one of those with you, Grant, so it can go out in the minutes and notes of this particular session. What it covers is just, as I said, a very simple agreement that the ICB in this particular instance purchased the chair. So yeah, we have the MOU, which we, as I said, we paid for the chair in the initial instance out of the HMWell funding. So it does state very clearly that although we've purchased the chair, there is a 2-year warranty with that chair, and the HelpFall app goes alongside that. So we have paid for all of that in one hit. At the end of the first year, the chair is serviced by Felgains, and obviously we're working closely with the care homes throughout the whole process anyway. But after the warranty is finished, after the 2nd year, essentially the chair becomes the care home's property. So we really needed to make sure that they were clear on that, and that after that 2-year period, the chair is theirs to therefore maintain. So it was just a really simple couple of pages, if that, agreement. We also sent a letter that went alongside the MOU just to make really clear what had been signed up to and what the process was. But as I said, the conversations between the clinical nursing teams and the care homes previously had already covered all of that. So the care homes knew what they were getting into. They knew what they were signing up to. This was just a bit of paper to say, yes, we agree.
Thanks, Mark. So next question, do you have a flow chart for care homes as to what happens after they are up off the floor to help reduce the risk of the next fall? Donna, maybe one for you, but in terms of built into HelpFall, no, there isn't anything. This is simply a tool to assess, is the person best left on the floor or lifted up? That's not to say that in the future we can maybe tie that in to encourage some more of that sort of holistic thinking, but not at its present state. Donna, anything from you?
So it would be no different to if a patient was falling and lift up using any equipment or no equipment at all. You would still want to do a root cause analysis. This is why that person was falling. It would be no different. This is just really a more comfortable and safe way with a clinical rationale to allow people to lift them up. But the data will show you patterns and times, and it is for you to look at reasons for falls really as part of your root cause analysis, I would say.
Okay, that's good. Next question. So does the HelpFall app include a multifactorial falls risk assessment? Natalie, one for you probably.
Yeah, so similar to last question really, it doesn't per se, but the information that is generated through the reports can support you in that process. It will also encourage you to make onward falls referrals where you have lifted somebody. Yeah, that's it. It gives you support in that process.
Okay. Next question then, talking specifically about a certain injury. So hip fractures are not always identifiable when the individual has first fallen. It can occur a little time later, depending on where the fracture is in the hip and how long it takes for the muscles to contract with the pain. How do you get around this? Maybe another one for you, Natalie.
Yeah, obviously, I'm not a medically trained professional, but what I would say is in terms of the safeguarding within the app itself, there is a prompt before you lift anybody to just make a mental reassessment for any signs of deterioration or worsening of symptoms that might have occurred, having not initially found any signs of injury. And obviously the lifting process itself with the razor, if you did start a lifting process and there was significant pain, it's easy just to safely put the person back down onto the floor if you need to.
I don't know if Mark or Donna have got any comments on that.
So I think with anything in health, no one fits squarely into any box, do they? So you have got to use a certain amount of common sense. So obviously, if someone has known osteoporosis or a known high risk of fractures or previous history of fractures, you may need to apply a little bit more caution, but that's about knowing your residents. And this isn't in place of a care plan, so you would still have a care plan, individual support and care plan for every person within the care home, and that would have to be taken into consideration around that. But I think what HelpFall does, it does give you all of the clinical things to think about, what you need to be looking for, clearly abducted hip and one thing and another. So there is some safety measures for you around that. The other thing to say is you would have to weigh up the risk of harm. I mean, if HelpFall saying to you this person can be lifted, but you know they've got osteoporosis, you're slightly cautious. Is this a very frail elderly person? Is there a likelihood that they're going to be there waiting for an ambulance for 6, 8, 10 hours? You know, the system's under such pressures. Is there more of a risk that they're going to have a huge pressure area there? And if the HelpFall app's telling you, you know, it's safe to lift them, and if you start the process and it's comfortable, is it better to get them off the floor as a lower risk? And that's something where your more profound risk assessments will come in and your individualised support care plan, I would say.
That's good. Thanks, Donna. You're right. It is sometimes a question of weighing up the risk, isn't it, of the two potential paths in which you can follow. There is a bunch of questions on here, so trust me, get through them all. One here: how do you ensure the residents that need the community 2-hour response are referred onto that team? Would you like the app to tell them which service to go to? I don't know who wants to pick up the answer to that.
Yeah. I mean, the thing is that the app's going to be used right across many different systems, and although everyone will have UCRs, they will generally work in slightly different ways or have different referral points. So I think you need to keep it fairly generic in there. But we certainly have been going out to all the care homes with the UCR eligibility criteria, what they can do, what they can't do, and how they can be referred into, just to ensure that it all ties up and links with this particular piece of work. At the end of the day, there'll be no point if you're picking the person up, sitting them in the chair and making sure they're comfortable, and then not referring them into the right place. And obviously there's got to be some responsibility on the care home to be making those choices, and they can only be making the choices with information. So that's what we've been trying to do in North East Essex, is just to make sure they've got the access to the right services to pull through the right response in the right time again.
That's good, Mark. Have you got anything to say on that?
No, I was just going to say in terms of within the app itself, where the UCR becomes relevant is in that amber minor injury section. So that is where the app will encourage you to follow up with the likes of UCR, depending on what service you've got in your area.
And as Donna mentioned earlier as well, with the enhanced health in care homes, if the care homes are receiving their regular weekly ward rounds with their local GP, then it's certainly something that can be picked up then. And even if they do call through 999, within North East Essex, we've got a process at the moment with the Cleric portal, which has been put in place by East as a pilot within our Eastern region, where our UCR teams can actually see Cat 3 and above calls from our stack and appropriately take them off the stack and take the clinical responsibility for them to go and respond to in our area. So we're able to have a real helicopter view from within the community teams of exactly what's happening within our system and putting the right response in the right place.
That's good, Mark. Let's jump on to the next question. So who takes clinical responsibility when residents in a residential home are not conveyed to hospital, i.e. an unwitnessed fall with no evident injuries? Natalie, probably one for you to pick up on, and maybe with the support of Donna or Mark.
Yeah, so in terms of the app and unwitnessed falls, the algorithm is designed to take into account that a fall may be witnessed or it may be unwitnessed. Regardless of whether it was or wasn't witnessed, we're still checking for new injuries and symptoms. But it may be in some areas that if a fall was unwitnessed, that's where you want to increase the monitoring afterwards. The app will generally advise you to monitor someone for at least 24 hours. And again, you might want to do a falls referral to get some a more robust follow-up.
Good. Next one on there, who pays for the lifting equipment?
We utilised some Ageing Well funds for this particular pilot. Obviously, we picked out 20 care homes and that gave the access to all the HelpFall app as well. I appreciate that these, particularly the razor chairs, aren't necessarily the cheapest bit of equipment. But as I said, and what Donna's conveyed earlier as well, there's a little bit more dignity than some of the other offers, I think, and a little bit more safer and easier to use. I think there's a bit of an economy of scale here as well, in the sense that you can use the data within your ICBs to identify the care homes that really need this. We also did some audit work with the care homes to understand who had lifting equipment, who doesn't have lifting equipment. The actual app itself and the licenses aren't that expensive if you put it into context. So even if they have their own lifting equipment, the app will enable them to actually make the decision making and utilise the equipment they've already got on site. We were trying to help out, as I said, not only the top 20 fallers in terms of the care home data, but the ones who had no equipment to use within the care homes either. So we have saved a lot of money elsewhere by putting this equipment in. But I think there's got to be some context around it. If you turn around and said, oh, the 160, whatever it was, care homes in North East Essex have a razor chair, it's going to cost a lot of money in terms of a mass wide rollout, when actually you could probably focus on the top 20 or 40 and actually make a huge difference in savings there as well. And just to note, we've also gone live with our North East Essex full service recently, and the care homes can refer into that directly if they're unsure, and that refers straight into the UCRS. So there are some economies of scale with filling the full service with the chairs and the HelpFall app as well, just so that we're really covering the basis as best as possible.
Thanks, Mark. Next question there, do you have a video of the process and the questions asked? Yes, absolutely we do. I think it's come up a few times. So in the email that we send around after, we'll maybe include a link to the previous webinar that we hosted, which goes through it in detail, the whole process from beginning to end, doing an actual assessment. Then one for how many care homes in your area don't have a chair, and who has paid for the chairs? I think you've covered that bit already, but this is very much the sort of tip of the iceberg, isn't it, Mark? Carry on, you can.
Yeah, it is the tip of the iceberg. We've gone for probably the easy, quick wins first, and now it's down to us to work out how we utilise the money best moving forward and put it into the right place, and support the right care homes. So as I said, those audits and things like that have been really key to find out where we really need to put the equipment and that risk. Some care homes have already got chairs or manga elks and things like that are different, and they're comfortable using those. So that's absolutely fine, but they could still use the app to help make that post-fall assessment, to use their own equipment, and still make the right decision and save the whole system a lot of time, effort and money and pressure.
That's well answered. Thanks, Mark. So next one here, are you requiring the care homes to have refresher training each year? At present, no, if I can answer on your behalf. I don't know if we've to be fair, in terms of the project, it's coming up for its first birthday, isn't it? So it's not something that we've considered just yet. May well be a good idea, because we are very aware that staff do change very frequently in this particular environment. So it's not a bad shout. Who would be responsible for competency assessments for staff? I could probably answer that one. So when we do the training, we would typically train a smaller selection of maybe the managers within the care home or the team leaders. And then we train them to a train the trainer standard. And then it's the expectation that they would then disseminate that training to the rest of the staff. And we support them by providing them with both videos, but also a competency checklist that they can use to assess the staff that they then follow on with the training. I don't think there's anything more to say on that. There is a question there, is the use of HelpFall a delegated healthcare task? I'm going to have to pass on that. I'm afraid I honestly don't know. Natalie, do you know the answer to that?
Not specifically. It's one of those things that is likely to be different in different areas. So it's not being designated as such, no.
Okay. Question from your neighbours over in Mid South Essex. Interested to know what process SNEE have put in place to have confidence that the person reviewing the post-fall report is reviewing and taking necessary follow-up actions. Is it normally the GP who receives the reports?
As far as I'm aware, it's the care homes documents that they receive. It's their reporting that they receive. They then use that to support the conversations with any clinicians in terms of the enhanced health and care homes and the ward rounds. The clinical responsibility as such is with them at that particular stage, like it would be for any decision making process for any of their residents. So there's nothing necessarily for the SNEE ICB to be worried about in that sense. We are simply supporting them with a decision-making tool that's given them the opportunity to have a bit more of a reassured decision-making process, quite simply. They would still follow the usual pathways and routes that they would have to in any other given circumstance.
Good, thanks, Mark. Another question there, probably touched on some of the answer here, but are there advanced clinical practitioners in care home to look at complex scenarios around falls? With head, hip injuries, falls can be serious incidents leading to a number of different further complications. Care home staff identify whether to wait, how do the care home staff identify whether to wait for paramedics or transfer the patient? Are there safeguarding in place? There's a bunch of questions in there. I think probably what we've covered is that we're simply assisting somebody to make an educated decision. I think particularly the benefit we do have with residential care homes is that they know their residents well, and they can often detect behaviours that are outside of what would be normal for that resident. And we're certainly not saying that HelpFall is to override any of that sort of gut feel or decision making. Obviously, HelpFall does have that minor injury section that we've talked about, which refers on to the urgent community response and the likes. But I don't know if there's anything more to say specifically on that comment. You are right. Carrying out any task has risks associated to it, and it's about managing that and looking at what the potential ways in which you can respond to that fall. Next question there, is HelpFall included for a period of time with the purchase of a new chair, or is it an additional cost? Short answer, it's an additional cost. It works on a like a care home type roller. It's a £19 per month per care home. It's a simple flat rate. Then the next one, what happens if you lift the patient according to the app's advice and then find that they are injured? Who is liable then? Great question. Natalie, it's probably one for you to pick up.
Sure. It's a little bit of a difficult one to say definitively, but we do know that within the Health and Social Care Act, it is actually stated that if a care provider can demonstrate that they have followed a process, they won't be regarded as liable for harm done during that care. And again, this is about following a process to make an informed decision to reduce the likelihood of that happening. That's good.
Right, let's move down. So yeah, we can send your competency checklist out. Right, the next one. So this one from Donna, that the SWASH traffic light assessment can be used as a standalone assessment as well as without the use of an app, correct? So Donna is rolling this out across 520 care homes in South West. It is well received by staff as a supportive assessment to guide around documentation and action. So thanks, Donna, that's a confirmation. But yeah, you're right, that as a principle, the traffic light system certainly isn't new. It's something that's been around for a long time. We've simply just turned it into a digital tool. So I do believe that is it on the questions. If we have missed any, then we can come back to them. Mark or Donna, anything else you want to say before we wrap up?
There was one that's just popped up about, if the pilot's demonstrating efficiencies, is any of the money saved going to be put back into the care homes? I mean, as I said, this was used from Ageing Well funds at this pilot stage to understand what was going to happen with it. So it wasn't care home funds in the initial instance, it was actually Ageing Well money that was used around the frailty and falls kind of element of that. I'm certainly not expecting care homes to be going out and purchasing the chairs kind of directly themselves without a little bit of support. I think there needs to be a bit more conversation about that. But if you think about the app being £19 a month for each care home, in theory, I could pay for the 160 odd care homes to have 3 years worth of access to that app for a very minute cost compared to what we currently spend in the rest of the ICB world. And I think that's got to be something that's really simple and easy to use on their behalf, but a great efficiency for us in terms of it may well cost me £10 to put some more HelpFall apps out into the care homes. But how much are we saving in terms of ambulance call outs, emergency department costs, nights in hospital, etc., for testing and things, when quite often we knew that those patients were being sent home with no abnormality detected. So I think there's some savings that we can make across the wider system for a small bit of investment.
That's good, Mark. Thank you very much, and thank you both for joining. So that brings us to the end. I trust it's been useful and you've learned some new things about HelpFall. We'll obviously send around a recording and the relevant items that we've been discussing as we go through the webinar. One thing I just wanted to stress is that as an organisation, we, I guess probably as has been evidenced with our conversation with SNEE just there, we kind of view it as our responsibility to take some of the hack work off the ICB. These projects are sometimes a bit of a challenge to get off the ground. So we view it as something that we have to do in terms of that kind of hand-holding process from concept through to actually getting this rolling. So that's it for today. The webinar will end now and we will be in touch with the relevant details in due course. Thank you very much all. Have a good rest of the afternoon.